Good afternoon, everybody, and thank you for joining us again for another one of our MAG-free medical specialist educational seminars. Today we have with us the very lovely Dr. Jim Muir, who is a Queensland-based dermatologist who has apparently lived his entire life in Brisbane. But even though I am a Queenslander, we won't hold that against him. Dr. Muir has been very active in dermatology across his profession. He's been involved with rural and regional treatment and care and has particular interest in skin cancer and skin conditions and skin disease in the elderly, amongst other things. He's quite well known in his field and highly respected, and we're very, very pleased to have him on our MAG specialist panel. Now, today, if I ask you, please remain on mute during the session so that noise from your home or office doesn't interfere with the presentation for others. There will be a time to ask questions at the end if you like, but if you have to go or you don't want to speak out, you can always type your question into the chat below. Without further ado, I'll hand over to you, Dr. Muir. Thank you.
Thank you. Thanks, Michelle. With questions, I'm happy to take questions as I go along. I find that's better.
Okay.
And you can typically type them into the little thing. And Michelle, if you keep an eye on it, if someone asks me a question, I'll try and answer it. So what they've asked me to talk about today is occupational skin disease. I guess the definition of occupational skin disease is skin disease that's caused or aggravated by a person's occupation. I think the audience is all well aware of that. So it's just got to be a significant contributor. It doesn't have to be the total cause. Often, if it is an aggravation, it'll be a temporary aggravation. There's a song, I like country and western music, but mamas, don't let your babies grow up to be cowboys. If you grow up and you work with your hands, so I think there's lawyers in the audience and dermatologists, we're not notorious for working with our hands, so we probably won't suffer from most of these things. What are the things that result in industrial skin diseases, occupational skin diseases? Well, there's chemical hazards, and probably, if you all remember back to COVID, the big chemical hazard we had was hand washing. So everyone went ballistic on hand washing. In dermatology, we just had hundreds of people presenting with irritant hand dermatitis. The other thing that happened, you probably all remember back, every now and then you'd walk down the street and see someone wearing their plastic gloves as they went around their daily activities. That's a great way to get an irritant hand dermatitis. But aside from irritants, there's also allergens that we come in contact with, and there's a whole bunch which I'll go through in a second. Photosensitizing agents. Very common cause of photosensitive dermatitis is paradoxically and ironically sunblock. It's a very common photosensitizer. Fragrances, in fragrance in cosmetics, etc., is a common photosensitizer. And then we have things called acnegenic agents, which, as the name suggests, induce acne. That's a big problem in people who work in mining or mechanics, and they get occlusive disorders, and it flares their skin up. And biological hazards, so things that can infect you, so bacterial infections, mycobacterial infections, fungi, viruses, and skin parasites, and we'll show you some examples as we go along. And then the physical hazards of work, so physical frictional trauma, injuries, mechanical pressure, radiation, UV, and in some professions, ionizing radiation, and extremes of temperature, cold and heat. About 20 to 30% of all occupational disorders are said to be skin related. So, it's a fairly major part of occupational medicine. How do you know if something's occupational? The big thing that you have to do is get an accurate diagnosis first off. I do a reasonable number of reports, and I'm on the Medical Assessment Tribunal up here, and it's far from rare for people to be sent in with what's being called an occupational dermatitis with a misdiagnosis. They haven't got the correct diagnosis. It's been attributed to work, and in fact, it's not. It's nothing to do with their workplace. And it happens a lot in the obverse, where people don't consider work as a causal or contributing factor and miss the opportunity to make the diagnosis of an occupational dermatitis, which is crucial because you're never going to fix them if they've got an ongoing trigger for their problem. And then you have to verify the relationship with the workplace, and which we'll go into as we go along. So the big thing we see is chemical issues, and the big thing we see there is hand dermatitis. That would be far and away the commonest manifestation of industrial dermatitis. What are the predisposing factors? The big predisposing factor is a history of skin disease in yourself, so history of psoriasis, for instance, but more importantly, atopic dermatitis, so people who have asthma, hay fever, atopic eczema. Chemical dermatitis can be irritant and or allergic, and they can both coexist. So irritant dermatitis, and remember the commonest one is just the old hand washing thing. So, you know, surgeons, nurses, bartenders, kitchen staff all get problems with repeated hand washing. Once your skin's inflamed, it loses its barrier function and you're prone to develop an allergic contact dermatitis superimposed. And sometimes, and I'll show you photos later on, we get allergic reactions to the things that we use to treat the original irritant dermatitis. Breakdown of the barrier function from any form of dermatitis means that things that previously weren't an irritant become an irritant. So if I go out and wash my hands 10 times today with the antiseptic solution on the wall at the hospital, won't cause me any problems at all because my skin's normal. But if you've already got a bit of dermatitis, that previously minor irritant will become a major irritant because your skin barrier function's no good. So who gets occupational contact dermatitis? Typically, you need, for irritant dermatitis, you need repeated exposure to irritants, or you need high concentrations of the irritants. Wet work is the big problem, all right? So if you're engaged in wet work, if your hand's being constantly wet, your barrier function decreases. If you're involved in extreme temperatures, that increases your risk of dermatitis. Frictional trauma, you know, people working with their hands, obviously you get injuries to your hands and you're more likely to get a dermatitis on top. Occlusion, I've seen many cases of people wearing protective gloves and they get the irritant that they're exposed to, and the gloves are supposed to be protecting them against, trapped between the glove and their skin. If you occlude something, you increase its absorption, you increase its irritancy. And those professions listed at the bottom there are the common ones. Hairdressers, we have an enormous problem with hairdressers and irritant hand dermatitis. Healthcare, so nurses, surgeons, wardsmen, they all get terrible irritant dermatitis. The construction industry, obviously, horticulture, catering and food industry. You know, every time you go to a function now, everyone's running around with their plastic gloves on. Rubber manufacturing, there's a whole bunch, you know. Contact dermatitis, they say it's about 0.5 to 1.9 cases per 1,000 full-time workers per year. But of course, that's a broad figure incorporating people like me or lawyers or accountants or office workers who don't come in contact with irritants or allergens. If you get the professions where you are in contact with irritants and allergens, the prevalence of contact dermatitis increases a lot. So in a tire company, you know, getting all crap all over your hands, washing your hands a lot, exposed to allergens, paraphenylene diamine, which is the thing that makes rubber black, they have a high incidence. In a cement company, wet work, lots of friction, exposed to a very good allergen in the form of chromate, a lot of people will get a contact dermatitis in that setting. So this is a study out of Singapore. The main sources of occupational contact dermatitis were the metal, engineering, building, construction, electrical, electronics, and transport industries. And the main irritants were detergents, wet work, solvents. So people clean their hair with solvents, and the oils and greases they're exposed to. And they're the big allergens that they found: chromate, rubber chemicals, and nickel. Chromate's interesting. Chromate's used in tanning leather, but the big place that we all get exposed is wet cement. And it's an interesting allergen in that bricklayers become allergic to chromate when they've been in the industry for 30 years, and they'll work with cement for 30 years, and then all of a sudden they develop an allergy. And for concreters, it's a career-ending allergy because there's nothing we can do about it. We can't make you non-allergic, and if you're a concreter, it's very hard to avoid wet concrete. And that's a big problem for those guys because concreting is a very lucrative career for a manual worker. So hands, what we mainly see is irritant contact dermatitis, less so allergic contact dermatitis. We certainly see mixed or sequential. So you initially get an irritant and then you get an allergic contact dermatitis superimposed. And sometimes it's, like I said before, from the treatments. So from the cleansing agents we tell them to use, from the rubber gloves we tell them to use. For the patient, it's the same. It's the same problem. They've got a hand dermatitis, which is a very limiting thing to have. It can ruin your existence. So who's predisposed to it? Well, we addressed this before, but people with pre-existing skin disease is the big predisposition. So what I'm showing here is, that's my registrar's hand there at the top and the lady's hands at the bottom. If you look at it, see how the skin markings, I don't know if you can see my pointer, have greatly exaggerated. So she's got hyperlinear palms, and that's a sign of atopy. So atopy is where we get asthma, hay fever, and eczema. And these people are very prone to getting contact dermatitis. That comes into play when you see teenagers with atopic dermatitis and they announce they want to become a hairdresser. And, you sort of have to tell them, well, give it a go, but you're very likely to develop industrial dermatitis, to develop occupational contact dermatitis, because you're predisposed from having, poorly functioning skin. So the big things that predispose to it: atopics, extremes of temperature, high humidity is a problem, dryness is a problem, working in freezer rooms. Typically, an irritant dermatitis will be on your dorsal hands. The palms of your hands are a lot tougher. It's usually a hand dermatitis. Younger workers are particularly predisposed. I think the reason for that is that the people who get hand dermatitis, they leave those industries and move somewhere else. Women are very prone to hand dermatitis, and a lot of them, because women do most of the work around the house and they're washing and wearing gloves and getting their hands wet, they have a non-occupational contribution and physical trauma, if you're a manual worker. What are the things that do it? Acids, alkalis, organic solvents. Duration of exposure is very important. So a mild irritant that comes in contact with your skin for a very long time and on repeated instances will eventually give you an irritant contact dermatitis. If you have a high concentration of an irritant, well, then obviously you'll get an irritant contact dermatitis a lot quicker. And once again, having it occluded. Phototoxic dermatitis, very uncommon, but we do see it with tar in workers, and that's where you need both the substance, which is a phototoxin, tar, and sunlight to trigger the reaction. Wet work we've already covered. Symptoms of irritant contact dermatitis: itching, burning. They often have a lot of trouble doing fine work because their skin's so inflamed. Workplace culture is very important in both prevention and causation. The workplaces where people take preventative measures very seriously, and mostly they do now compared to 30 years ago, have a lot lower incidence of problems where they have all the proper mechanisms in place. I can't really go into we'll cover it briefly, have a very different outcome. Those are the occupations, we've addressed this earlier, that are prone to hand dermatitis. So repeated exposure and beauticians, that slide's come up twice. All right. So they say irritant contact dermatitis, as opposed to allergic, comprises about 80% of all of the occupational skin disease. Can be a single episode, but more commonly it's repeated discrete episodes of being exposed. And you can develop a condition called persistent post-occupational hand dermatitis, where if I have an occupational hand dermatitis, let's say I'm a registered nurse, I'm working in the operating theatre, I can't afford to quit, I develop a hand dermatitis, it goes on and on, I struggle along, I put my steroids on, my hands are inflamed for 6, 12 months, 2 years, and then I finally run up the white flag and I remove myself from that job. Very common to see that hand dermatitis just continue, even though they've been removed from the causative environment. And presumably that's because the barrier function is severely compromised and everyday irritants are keeping it going, and or they're being exposed to allergens. Eventually that will recover. So that's an example of exposure to an acute caustic. So this is a guy who got his hands exposed to bleach, undiluted bleach, and got a terrible injury. So that is an irritant dermatitis. Dermatitis just means inflammation. Probably most people would classify that as a chemical burn, but that's a one-off exposure. Similarly here, you can see how severe these things can be. And, mostly these people will recover. That's been so severe that you've got development of pus. That's not infected. It's just from the severity of the injury from the caustic. This, on the other hand, is the common presentation of irritant contact dermatitis. As you can see, it's over the dorsal aspect of the hands. I'm not sure if I got a photo of the palms. At the palms, I don't think we're affected. And it's got erythema, redness, got a bit of scale, got a bit of micro fissuring. Now, that's an occupational hand dermatitis related to hand washing, chronic wearing of gloves. When she goes home, goes to the bathroom, cleans up after dinner, she's going to get a contribution also from her non-occupational exposure. So often there's multiple factors at play to develop an irritant dermatitis. Multiple irritants, possibly some allergens, wet work, friction, occlusion, low humidity environment, all of those things, high temperatures, all of those things will contribute to it. And, if you can address some of them, you might get on top of it. Sometimes we can't, the only solution for some people with industrial dermatitis is, mate, you've got to get a different job. There's no way that we can fix this while you continue in that job. To illustrate, I had a very senior nurse who was completing her intensive care qualifications, and she was working in the neonatal intensive care. So neonates are defined as within a month of birth, and she was washing her hands 50 times a day, had a very awful irritant hand dermatitis, and there's nothing I could do. While she remained in that job, nothing would make any difference. Putting her on prednisone, giving her immunosuppressants, phototherapy, topical steroids, emollients, all of those things will make a little bit of benefit, but basically the problem's going to continue. But she only had 6 weeks to go before she completed a qualification, and so she just soldiered on. But sometimes, I just have to tell them, you've got to change jobs. All right. Wet work, that's how it's defined. Exposure to wet conditions for 2 hours or more per day, very individualized, how much that's going to make a difference. If you've got a pre-existing skin problem and you're atopic, much shorter periods of time, then that can be a problem. If you wear gloves all day, that is a very irritating thing, that will make your skin inflamed. All right. And frequent hand washing is a problem. Like I said, during COVID, it was just everywhere. People were just going crazy washing their hands. And we've talked about persistent post-occupational hand dermatitis, and that's an example. So you can see this is a lady, this is well over a year after she finished her job, where she was a cleaner, 2 or 3 years of severe hand dermatitis from exposure to irritants and allergens in the workplace. Even when we removed her from that environment, her skin was so damaged, so inflamed, that the condition just persisted. And you can imagine, having hands like that is a very debilitating problem. It's very uncomfortable. It makes doing your shirt up, doing fine work, chopping vegetables, any sort of work around the house extremely difficult. This, on the other hand, is interesting. When you're looking at a rash, sometimes where the rash isn't nearly as important as where the rash isn't. And as you can see, he's only got it where his shirt covered here. All right. So he was exposed to petrochemicals diluted in he got a spillage, and he kept working even though it was all petrol and stuff like that. And that gave him an irritant contact dermatitis, and he's got pustules. He also had some exposure in his wrists under his gloves, he said. So he had gloves on and it got under his wrists, under the gloves, trapped between the gloves and the skin, and he got an irritant contact dermatitis. Now that's an acute one-off injury that will just disappear with treatment. Skin's luckily a very resilient organ and will recover nicely. This, on the other hand, it's not an occupational dermatitis, but this is a thing we see increasingly with, if any of you look in your laundry at home and you've got laundry agents that are said to be germicidal, kill germs, like Canestin Plus. This is due to a chemical in those laundry things called benzalkonium chloride, which is quite a good irritant. And there's a absolute plague of this happening at the moment. You see it, and it's due to remnants of the laundry detergent in their clothing, and it comes in contact with the skin and causes an irritant dermatitis. See how the top of the armpit there is spared, and that's because if you sit there and think about your armpits at the moment, your shirt doesn't come in contact with the top of your pits, and so only the areas in direct contact. This just to illustrate the effect of occlusion. All right, so this lady's got a big ring. When she gets her hands wet with soap, she traps a bit of soap and water between the ring and her finger, and it gives her dermatitis. So if she gets, it's not an allergy to the ring, it's just an irritant dermatitis from the detergent trapped between the ring and her finger. And that's an aggravating factor of the irritation. So allergic contact dermatitis is different again. So that's an immunological response. So you become allergic to something that comes in contact with your skin. So you initially have to get sensitized, and then re-exposure causes the rash. So with an allergic contact dermatitis, it's not the first time you get in contact, it's the 21st or the 31st that you get the reaction. Any of you out there with piercings, some of you will probably say, I can't tolerate cheap piercings. I've got to have surgical steel or pure gold or pure silver. Otherwise, I get an infected earlobe. That's not infection, that's allergy. You're allergic to nickel and or cobalt. And so you initially get the piercing, the nickel and cobalt's in there, you become sensitized, you get an allergic reaction to it. They may be already sensitized and then come into the workplace where they're exposed to that chemical, and that will cause them to have issues. And the reaction can take quite a while to come on. And an unusual thing that can happen is, and I'll show you a photo, is you can get a localized allergic reaction to a workplace chemical, which can then generalize over your whole body. So the occupational allergens we see, nickel. So hairdressers are notoriously allergic to nickel. Paraphenylene diamine is a dye, and it's found in black rubber. A lot of the chemicals that are used to cure rubber are allergens, very good allergens. Resins, the two-pack glues where you mix them, epoxy resins, they're a very good allergen. Biocides used in animal feed, so antibiotics are a good contact reaction. Preservatives, everything that's a cream, got water in it, will contain preservatives. For example, parabens, which you all would have heard of, that's a good allergen. Animal feeds often contain allergens. There's a bunch of plants out there that we get allergic to. The common ones in Queensland, where I am, are mangoes and grevilleas. So mangoes are very good allergens, the sap, a range of pharmaceuticals, and then fragrances used in a whole range of places can cause photodermatitis. So this is called dermatitis medicamentosa, just to show you an example of a contact allergy. So this lady's got a piercing, and my registrars always say, oh, she's got a nickel allergy. But when you look, the skin around the piercing's not too bad. She was given a topical antiseptic ointment to apply to stop secondary infection, and she's had a reaction to it. And here, there was a cut on the leg, and they were given a topical antibiotic cream to apply, and they've had an allergic reaction to the topical antibiotic. So the treatment can become the disease. So that's why we call it dermatitis medicamentosa. This guy, if you're wearing shoes with a tongue, if you think about shoes, they're not made of one substance. They're not just leather. They're leather and rubber and glues. And the leather contains allergens, the things to cure leather. It also contains dye. The rubber contains allergens. So here, this person's allergic to something in the tongue of their shoe, aren't they? Because they don't have a reaction elsewhere on their foot. So the tongue of the shoe is the allergen, and in this instance, it was rubber chemicals. This lady is in her 60s, 70s actually, and she's got a terrible problem on her face. What's wrong with her for being in her 70s? She's got very dark hair. So she's got an allergic reaction to hair dye, which is paraphenylene diamine. All right. Here, what's the allergic reaction? Nickel. All right. So these are just all examples of nickel, of allergic reactions, not necessarily nickel, but not necessarily occupational. And this guy, I don't know, bunch of Sydney lawyers, you're probably all wearing thongs to work. That's an allergic reaction to the thongs. And so he's allergic to rubber, and that's called a purpuric contact dermatitis. So that's a rubber contact dermatitis. I had a gold miner many years ago who had a terrible allergic reaction to his rubber protective boots and had the exact same rash as this, except it went from his toes to just below his knees. And here, this is a worker who came to see me for a report, and this is the photos he provided me with. He put on a new pair of heavily dyed socks and developed this reaction over the course of the day. You can tell it's the socks because where the socks stop, the rash stops. So this was an allergic reaction to the dye in the socks. And we had a big problem with this with high-vis clothing about 10 years ago. For some reason, the manufacturers used a dye. It wasn't very well fixed. And a lot of workers were getting very similar reactions to this, but all over their trunk. So that's allergic contact dermatitis to the dye in socks. And, clearly an occupational dermatitis, but once again, you'd expect that to completely recover without any sequelae. Now, this man came with this rash, but when you took his history, it began on his lower limbs, where he had a allergic contact dermatitis to his footwear and it generalized. So that's an example of generalization. We talked about that before. Now, it's very rare, but it's possible to become allergic to gold. So this lady came in and she had this present from her husband. It was an anniversary present. This is sort of an aside. And I said, oh, you know, do you get a reaction to earlobe piercings? And she said, yeah, I get infected earlobes. And I said, well, you're probably allergic to nickel and cobalt. This thing will have nickel and cobalt in it. That's what you're allergic to. She says, oh, no. This is pure gold, this necklace. My husband gave it to me for our anniversary. And I said, oh, I don't think so. I think it's got nickel and cobalt in it. So I did the test. You can test it. We wipe on a chemical, it changes color. And of course, it was nickel and cobalt. And I think it led to a divorce. But you can actually be allergic to gold. And so I've told my wife she's allergic to gold. So it's a lot cheaper in the present department. Now, airborne contact dermatitis can happen. We see that with agricultural workers and carpenters. You can become allergic to pine dust, for instance. You know, that's an interesting allergy because the stuff in pine that you get allergic to is the same as the substance that they use to make sticky tape, sticky colophony, and people get allergic to that. So you can imagine if you're grinding up an allergen, it's in the air, it will settle on you. Any of you guys who've done a bit of sawing, you'll settle on you and you'll get an allergic reaction to it. And you can see a whole list of things there that people get airborne contact dermatitis to. And you can also get a thing called contact urticaria, which is a form of anaphylaxis where you get hives in relationship to contact. I won't go into that. That's a fairly rare thing. But it's something that we can diagnose, although often you have to base the diagnosis on history, because with urticaria, by definition, the rash disappears in less than 24 hours. And so we may not have anything to go on when they present. So here's a lady who worked as a person who cleans up your yard. I don't know, lawnmower man, I guess, lawnmower person. And she's got the classic pattern of a plant contact dermatitis. So plant contact dermatitis gives you a streaky rash because when you think about it, when you're handling things that you're chopping down, you get streaky application of it to you. But at the same time, she was, and you can see how severe it can be. This is a big problem, very itchy, very unpleasant. But look at the cutoff. See the cutoff above and below? No rash, lots of rash. That's where her ankle socks came to. When I took the history, she was chopping up plants with scrub hooks and saws and gathering them up. And then she had an industrial whippersnipper and was vaporizing them with that, spraying allergen all over the place, which settled on her and gave her that background diffuse eczema. So that's an example of an airborne contact dermatitis. And that's the streaky nature of a plant contact dermatitis. All right, see the cutoff. So where the allergen doesn't reach, there's no rash. So how do we make the diagnosis? You've got to suspect it in the first place. You've got to take a very thorough history of what the person does in the workplace. One of the big things is with an industrial dermatitis is, do you get better when you're away from work? And often, even a weekend away from work, their skin will improve, even with a severe reaction, will improve a bit and then flare. If they go on holidays or get sick leave, it'll improve a lot. And then if it's an allergic reaction, it'll come back as soon as they go back to the workplace. If it's an irritant contact, it will slowly recrudesce if they haven't taken measures to get around it. If it's an allergic contact dermatitis, so for instance, to hairdressers, to substances used within the hairdressing industry, they're everywhere within the salon. So even if they change their direct interaction with their clients, they'll still get a reaction. So the time course is important. Did you have the rash before you started that job? How long into the job did it develop? What's been the history since then? And then for allergic contact reactions, we do appropriate patch testing. There's endless allergens that we can test for, and I'll show you how we do that. Examination is important, and making sure that you've got the diagnosis correct. So this is an example of patch testing. We put the allergens on their back, and if they've had a reaction, we can say, all right, you're allergic to whatever it happens to be, fragrance, paraphenylene, diamine, nickel, cobalt, rubber chemicals, etc. Then we can sort of go backwards and reverse engineer that test and say, Are you being exposed to these substances? Are you being exposed at home? Are you being exposed at work? Sometimes the patch test is irrelevant, so we'll get a positive result to something that they're no longer being exposed to, so that won't be the trigger. Unfortunately, you also do get false positives and false negatives. And these are the things we go through to work out if a dermatitis is work-related. So is it consistent with a contact dermatitis? That's usually a reasonably easy diagnosis to make. Are there things in the workplace that would cause it or predispose to it? So what are their activities? What do they have to do? Do they have to wear gloves? Do they get exposed to irritants? Do they get exposed to allergens? Is the anatomical distribution consistent with cutaneous exposure? So if they're wearing full PPE and they're getting, a rash, they're getting a rash on the top of their buttocks that looks like psoriasis, well, it's not going to be a contact dermatitis. All right. The temporal relationship we've been into, are there non-occupational exposures that could be at fault? Lots of allergens that occur within the workplace are also found outside of the workplace. Some allergens are unique to the workplace. I had a man some years ago who was a carpet layer, and he was clearly allergic to something in the carpet laying industry, which we could never identify. If he went away from that industry, the rash would disappear. If he came back to it, he'd get the allergic contact reaction back, but we were never able to identify the allergen. And can we do the patch testing to confirm that diagnosis? Material safety data sheets are useful. I mean, obviously they're mandatory to have. They're not always complete. When you're talking about allergen, it doesn't have to be present in a high concentration to still be a problem, and some of them are inaccurate. They often don't mention substances that are present in a low concentration. Patch testing, like I said before, has a range of responses. We do get false negative and false positive reactions, unfortunately. They're not always relevant, and I've explained why. So prevention is very important in the workplace, that they identify workplace hazards. It's very clear in a lot of jobs, that frequent hand washing is going to be a problem, exposure to irritants is going to be a problem, exposure to wet concrete is going to be a problem. The workers have to be educated in how to do it and how to avoid it, what the hazards are. You should take all possible measures to reduce exposures. You've got to have PPE, personal protective equipment, that they can wear, that's functional and that also works. Not all gloves are useful with various irritants. If you can minimize wet work, if you can minimize exposure to extremes of temperature, if you can keep their prolonged glove wearing to a minimum by altering their workplaces, using protective things, beneficial things like emollients, soap substitutes, keeping an eye out for it and getting data on how many problems you're getting. Career counselling is important. Sometimes you just got to tell them, mate, you cannot continue as a concreter, or you're a 16-year-old with severe atopic eczema. I would strongly suggest you do not pursue a career in hairdressing. You're not going to tolerate it. And avoiding the irritants and allergens. So here's an example of what can be. So this is something that you might use to treat it, and it says it's free of parabens, but it's not free of a lot of other things. So they can get, if you've already got hand dermatitis and you're using something with a very complex and lots of different chemicals in it, you're very likely to get problems from that. Won't have time because of time constraints, but there's a range of protective gloves that you can buy. Not all gloves are protective against all chemicals. So you have to wear PPE that's appropriate to the job at hand. Soap substitutes can be very useful. A lot of stuff, like if you next time you go to your mechanic, see the stuff they clean their hands with, it contains abrasives to get rid of all the grease and oil. That'll wreck your skin with regular use, especially if you're predisposed. Moisturizers are useful. Barrier creams don't work. It's not gonna. It's not truly a barrier. You wipe it off. It's not going to work. Treatment, we can usually treat them. Typically, they only need topical steroids, but sometimes we have to go on to more severe treatment. But the big thing is we're never going to win unless we've made the diagnosis of an occupational dermatitis and identified what the causation is and remove that from the paradigm. Occupational acne, basically that's just an acneiform, acne-like eruption, or it is indeed acne. And the big thing we see that with is mechanics and coal miners and people like that exposed to grease and crap all over them all day, especially if they're working in a hot environment. It's interesting. I was reading a historical medical thing, and they said one of the big reasons for soldiers during the Vietnam War to be invalided out of the field was flaring of their acne from wearing camo and wandering around with wet clothing and in high sweaty conditions all day. We do see skin cancer secondary to chemical exposure. If out of interest, the very first occupational malignancy ever described was done by a guy called Percival Potts, who was a doctor in 19th century England, and chimney sweeps had a very high incidence of scrotal cancer. So they got squamous cell cancer of the scrotum. The little boys, they start as little boys, sent up chimneys, they're covered in soot all day, and because that's a carcinogen and they were constantly had it, couldn't clean, they developed terrible malignancies of their scrotal skin, which, as you can imagine, was incredibly unpleasant. But there's lots of other things out there. Arsenic's around. It's found in the gold mining industry. For instance, we used to have a lot of trouble with arsenic because it was used as cattle dip, and arsenic stays in the environment. Prevention, well, we've been through that. I won't go through it again in interest of time. Occupational infections are not rare. So we get predisposed to bacterial infections, so the occupational pyodermas from various occupations, working in dirty environments, working where you're wet all the time, working where you've got lots of minor trauma to your skin, working where you've got hand dermatitis. There's a whole bunch of things. Erysipeloid's a funny infection. We see it in butchers. In pathologists, they can actually acquire TB from the people they're doing autopsies on. That's not something you see much anymore. Mycobacterium marinum, I'll show you an example in a second. You see that a bit in guys who work around swimming pools, blokes who work on trawlers, people who work in the aquarium industry. There's a very not uncommon infection, which is, you might have heard of Rocky Mountain spotted fever. This is basically the same thing. Queensland tick typhus, which is transmitted by ticks. So you see that in people who work in areas where they get tick infections. And Candida, thrush complicates wet work. So that's an interesting lesion on the dorsal aspect of the hand. That's a granulomatous infection with an atypical mycobacterium. How did this guy get it? He got bitten by one of these, which is an aquarium fish called a red devil. And at that site, he must have had Mycobacterium marinum, which is a mycobacterial infection, implanted with the bite and developed that. This guy's a farmer and he's got an atypical mycobacterium in the skin of his hand there. And so that is a devastating infection. They can be very hard to treat. This is my only ever example of Lyme disease. And this gentleman returned to Australia after working in the Black Forest, where he was bitten by a tick a few weeks earlier and had this rash, which is classic, called erythema chronicum migrans. And so he had Lyme disease, the Borrelia burgdorferi condition, which resolves with doxycycline. Lyme disease is not as yet proven to exist in Australia. Then there's a whole lot of other infections, obviously bee stings, arthropod bites. Orf and milker's nodules are viral infections of sheep and cow, which can be transmitted to the worker. This was sent to me as an industrial dermatitis related to his workplace, but that's just tinea, widespread tinea that hasn't been treated. This guy had this rash for 3 years. It was related to the occupation he worked in, which was a factory worker. It would get worse when he's at work, but his workplace conditions were very hot. But when you examined him, he had the widespread rash. He had these lesions on his buttocks and he had scabies. So he'd had scabies for 3 years, so it wasn't an occupational rash, but he was misdiagnosed. Once the misdiagnosis was labelled, nobody overturned it until they examined him properly. And there I was able to dig the mite out of his skin, show it to him under a microscope, treat his scabies, and he was cured. These are purpuric insect bite reactions in a farm worker, and these are bullous insect bite reactions. So you can see they can be very severe. And this was occupational, as she was an outdoor worker. So physical skin disease, mechanical trauma, so callosities, and then extremes of temperature. So miliaria, you might know it as prickly heat. intertrigo rash in your groin. You know, all of these things can occur with extremes of temperature. So that's intertrigo exacerbated by working in hot environments. That's infected miliaria. So this guy went out, worked in a very hot environment, wearing greasy overalls, got miliaria, got secondarily infected. I'm almost finished. Ionizing radiation, pretty localized now where you see it, but you can still see problems in the diagnostic and therapeutic radiology industries. However, lots of workplace health and safety measures in place, so we shouldn't be seeing that anymore. But the big thing we still see is UV radiation. You guys drive past a workplace now, everybody's wearing high vis, everyone's wearing hats, everybody's got lots and lots of sun protection, except for self-employed concreters. All right, they're the only ones running around in stubbies and boots because they're not in work cover. All right, they're self-employed. That's my theory anyway, because they still remain resistant to wearing, unless they're an employee, to wearing sun protection. But obviously, outdoor occupations, prevention's crucial, and we're pretty good at it now. Surveillance for early detection of malignancy. One of the big problems in Australia, and I do lots of reports on this, is my sun damage occupational or non-occupational? People have very poor recall of their lifelong sun damage. If you live in Australia and you're Caucasian, you'll have sun damage. It begins soon after birth and it ends when they screw the lid down on your coffin. Working out if your occupational sun exposure is a significant contributor can be quite tricky. People give very inaccurate histories. Sun exposure can do funny things. So here's a guy with psoriasis who works outdoors, and as you can tell, where he gets the sun, he's got no psoriasis. We use that to treat it. Here's another person with psoriasis who got sunburnt, and their psoriasis flared up in their sunburn area. So it has paradoxical effects. Now, the reason I'm showing you this is not because it's occupational, but the next rash is, this is erythema ab ignate. This is a chronic injury to the skin from infrared radiation. And this poor fellow had chronic anal pain after cancer surgery. And the only thing that would relieve it was sitting in a hot bath for 17 hours a day. When we fixed his chronic anal pain, this all went away. It's important because it can lead to malignancy. Now, this is workers' comp. He had a compensable injury, low back pain, and he was treating it with a wheat pack. And you can see he's got the same thing. There's his scar from his surgery, and he's got the same problem, erythema ab ignate, infrared radiation damage here. So this tells me, what's it tell me? His pain relief's no good. All right, he's got inadequate pain relief because he's having to leave a hot wheat pack in place all day long, basically. So we had to get his pain relief optimized. This is just a rash from chronic walking, okay, from standing up, and you can see the blister. This is a guy who had a motorcycle injury to the way to work. It's buggered his lymphatic drainage, and because of that, he's got eczema in the area of compromised lymphatic drainage. This was sent in as a foot dermatitis, allergic reaction to his footwear, which it wasn't. What it is, see how he's better underneath where his straps go? So he's got eczema where he's got no eczema where he's got pressure. He had a DVT, deep venous thrombosis in this leg, and the pressure from his footwear got rid of the eczema, but where he had no external pressure, he had eczema. The other foot was completely unaffected. If he had an allergic reaction to his footwear, you wouldn't get it on just one foot, would you? It'd be unless you wore one shoe. This is also a complication of a workplace injury, once again going from work, terrible accident, and now he's got a verruciform change, wart-like change in his skin from chronic lymphedema. And the reason he's got chronic lymphedema, so blockage of the lymphatic drainage of his skin, is that because he almost lost his leg from the injury. So last couple of slides, facial lentigo maligna, and a nose basically completely consumed by skin cancer. And there's a melanoma on the back. So the big thing is my occupational exposure a significant contributor to me developing this skin malignancy? And that's based on a very careful history and examination. They'll come in and tell me, yeah, no, I've not had any sun exposure outside of the workplace. Do you ever go shirtless in the workplace? No, never go shirtless in the workplace. Then when you take their shirt off, they've got terrible sun damage in their back. So they're obviously misremembering or lying to me. But the term significant is also difficult. When I first started doing them, I asked them what significant meant, and they said not insignificant. And I said, okay, I'll bite. What's insignificant mean? And they said not significant. And there's no percentage figure, as you guys all know. I might call it quits there. Any questions?
Well, firstly, I would like to say thank you very much for a very comprehensive session, even though I acknowledge you went through more quickly than perhaps you'd planned. But wow, some of those images are absolutely stomach turning. And my greatest takeaway was that the Caniston wash, that armpit thing, that incredible.
It's terrible. It should be banned. We get it all the time, and it just drives us insane. You know, it's completely unnecessary. You can't make clothing sterile in a bloody washing machine. It's nonsense.
Yeah, yeah. I've got a question from someone who was unable to attend, and what they were asking was, and you answered part of the question when you said that emollients don't really work. They're a placebo type of thing.
Oh no, they don't work as a barrier. They're very useful for treating dermatitis, but you can't put a barrier cream on that will protect you from irritants effectively.
Right. Okay. And so the second part of that question then was, do alternate barriers such as cotton gloves inside a latex or waterproofed type of glove try and mitigate these conditions, or does that not?
If you're allergic, they won't. All right. If you're allergic to chemicals in the rubber gloves, the cotton gloves won't help you. You'll still have a reaction. All right. For minor irritant and dermatitis, a cotton glove can be useful. The big thing is, the gloves can be protective because they keep the irritants from getting in contact with your skin. So if you wear washing up gloves and you're doing the washing up for 15 minutes, you're not going to get irritation from the detergent. If, on the other hand, you wear those gloves all day and your hands become hot and sweaty inside those gloves, you're going to get problems. And the very common thing we see is poor glove wearing, not changing them frequently, getting irritants and detergent or whatever it is they're using trapped between the glove and their skin, and it actually exacerbates the problem, or using the wrong glove for the purpose at hand and it doesn't protect you.
Right. Does anyone have any questions that they'd like to ask of Dr. Muir?
Hi, Dr. Muir.
G'day.
Thanks so much for the session. It was really good. Could you comment about scarring as a result of any of these kinds of allergies, conditions, whichever you've gone through, and how scar revision can work, and those as well?
Well, typically with a dermatitis, you won't get a scar. With an eczema, you may get things that people interpret as a scar, which is pigment change. So the big thing they'll get is post-inflammatory hypopigmentation, which very often is not permanent. It will recover over time, but that won't be a scar per se. They'll perceive it as a scar. They'll perceive it as a disfiguring mark, which is, fine, disfiguring mark after their skin problem. Those photos I showed you of the blisters, the hemorrhagic blisters on the hand after exposure to a caustic, they could lead to scars, especially if there's secondary infection, but they're usually not going to be all that severe. But you can certainly, I'm just doing a medico-legal at the moment of a kid who got terrible burns from a caustic agent and got full thickness necrosis, and of course has very devastating scars. The big place that scars come up is in skin cancer surgery, and they're well, obviously inescapable. What was your question again? Sorry.
Ryan?
It was just for you to comment. I was curious. You've in many ways already answered the question, helping out with the difference between differences in pigmentation versus scarring. But
yes,
just
a lot of things get caused scars that aren't scars. That's common.
Sure. And then I guess it was just curiosity as well, whether you had any thoughts or comments generally about scar revision of any of these kinds of just treatment in general for
well, scar revisions I don't know how many plastic surgeons you guys know, but plastic surgeons love doing scar revision, especially on their own scars. They're never happy, not never, but very often not happy with their own scars, which are often extremely good, but they can make them do better. We often get people, we'll get sent people with scars after some sort of traumatic injury in the workplace, or with scarring from skin cancer. And depending on the circumstances, they can often be revised by the plastic surgeons. And there's also things you can do to improve the appearance of scars. If we get what's called hypertrophic or keloid scars, we can inject them with steroid. We can prevent poor scarring with silica gel dressings. One of the things we see is scarring, post-operative scarring from skin cancer surgery, where the original operator may not have had enough training or expertise to give the patient the optimal outcome, and we can easily fix that just by reoperating and doing a better job. And also, sometimes the plastic surgeons surgical repair of a skin cancer, you might do a repair which is done to allow you to reoperate if you need to, and then you do the definitive surgical repair maybe a year or two later when you're sure the lesion's completely cured, and you give them a much better cosmetic outcome. But no, scar revision is routinely done and can result in much better outcomes for the patient.
That's really
Wow.
appreciated. Thanks, Dr. Muir.
No worries.
Well, Dr. Muir, again, thank you so much. That was really, really interesting. Thank you, everyone who joined us today. The recording of this will be released in audio form only, not the visual, to protect the identities of the people whose images you saw. So those of you who saw that today, you're the only ones who will see that. A paper that Dr. Muir has done will also be sent out to you with that recording. We look forward to seeing you at our next seminar. Of course, all of our seminars can be accessed on our YouTube channel, and Dr. Muir can be booked for an assessment for your clients through contacting the team at MAG. Thank you all and have a great rest of the day.
Thanks, fellas. See you later.